am and what I do, but my background is as a learning disability nurse. I did a conversion to mental health nursing 10 years ago, and I now have sort of stepped up and manage two teams, really, a youth team. So you probably know the youth pathway, 14 to 25 in Norfolk and Suffolk Foundation Trust. So I manage that team, and I manage the under 19 Suffolk Eating Disorder Service. So we get given two teams rather than one to manage. That's kind of the way it goes, really. So for the last 4 or 5 years, I've been managing the youth team. So that's 14 to 25 young people presenting with different forms of emotional difficulties, and the under 19 eating disorder service. So that's me, really. So you've kind of, in some ways, it's quite good because I've got both experience of eating disorder and young people's mental health. So I'm sure I can answer any questions or stuff. Yeah.
Okay, well, thank you. You're very welcome, Chris. So over to you.
So who's here? Who's here just generally? I know we haven't got time to. It would be nice if we had time to introduce everyone, but generally, who's here in terms of people's roles and responsibilities?
So generally, I think we've got people that are pastoral leads, Senkos, quite a few of our members of staff from the Radworld Trust, so alternative provision, teachers, support workers. So that's generally our field.
Cool. Okay. It's nice to meet you all anyway. I don't know who you all are and stuff, but it's nice to meet you all.
Okay, well, I'm going to mute myself now, Chris, so over to you, and there'll be some time for questions and answers, I hope, at the end, if that's okay with you.
Okay, and just in case, I don't know what system we're on, but please feel free to, I see there's about kind of 9 or 10 slides, and I've had a quick flick through them. There's nothing there that kind of concerns me in terms of what I'm doing, but please feel free to, this is kind of really about joining together and thinking a bit together about, young people's services and eating disorders per se, really, isn't it? So I don't want to just spend the next half an hour saying this all out loud because you've read them.
Okay, well, if anyone wants to chip in, please do feel free to unmute yourselves and ask Chris a question. Is that all right as we go through?
I'd much rather we did that because I think that dialogue is going to lead more. You're going to have your own experiences of young people, and if you're sort of sitting there thinking, God, that's not what I've heard or not what I understand, you're just going to be frustrated. So don't know if you have a putting your hand up thing here. I can't see that. So just butt in, or if you do have that.
Hi, Chris. I'm Laura Leader from Radworld. There is a hands up option.
But so could someone monitor that for me and again, just interrupt me because yeah. Okay.
Yes, definitely.
So do I need to share the slide, or am I okay with you looking? If I tell you on slide 2, have people got them?
No, people don't have all the slides. So if you're able to share your screen, that would be helpful.
Wow. How do I do that? We're not on Teams. Are we on Teams?
We are on Teams, yeah. So at the top or next to your microphone, there's the little rectangle with the arrow, yeah.
Let's see. Is that working?
That is working, yes. Although we need to see it in slideshow preview at the moment. We can just see your PowerPoint open.
So I just click slideshow at the top?
Yes, and then it should say from beginning, start from beginning on the left-hand side.
Yep, click on that.
There we go, perfect.
Okay. So what we've got here, the first slide, is thinking about the increase in referrals to eating disorder services. So like I say, we cover all of Suffolk. We've just merged, really. We used to have a separate West Suffolk team that covered, obviously, the west of Suffolk, based in Newmarket and Bury. And we've now merged with the East, hence my job changing and managing both teams in the East and the West. And we're trying to join them together and look at our own kind of service development and how we support young people and families who present to our service. COVID has brought with it massive complications for us, really. So the slide after this will explain why, but a significant increase in referrals, and you can see across there, going back from across 2020, really, up until December, you can see the increase in referrals compared to the year before. Probably wouldn't surprise anyone at all, really, for the following reasons. So young people are sitting at home doing less, I guess. Obviously, they're hopefully most of them doing some schoolwork from home. They've got too much time to think, so there's a lot more time spent on social media, comparing themselves to others, thinking about kind of ways to be healthy, thinking about mental health and exercise, but actually sometimes becoming slightly obsessed by some of these things. Young people have less distraction. They're a bit more stuck in their rooms. They've got more time to kind of mull over things and kind of contemplate things, think about, like I say, how they look, compare themselves to other people. So it's kind of a extension, I guess, in many ways of kind of a normal side of adolescence and kind of what can happen kind of when people develop problems with their identity, really, which is what eating disorders are related to. Limited activity, so they're doing less, so kind of that's all combined really with the other two. Disruption of normal patterns of eating, shopping and meal prep. So so I guess what are families doing, how are they coming together, does that change at all? So again, over the past year we've noticed, I guess, that I guess you'd think maybe families would come together more and there'd be more sitting around the table and eating. We haven't really seen that. We've seen a bit more kind of chaos. We've seen more frustration at home, understandably. We've seen more kind of disagreements, arguments. We've seen people doing their own thing more. So, it's kind of maybe to be expected with COVID. But yeah, again, that's what we've seen over the past year. So, how are families joining together to have meals? What's going on? How are families in terms of split families? Young people spending time with mums and dads and different people, how does that impact? How do people notice that young people are changing their eating patterns, the amount that they eat? Are they counting calories? Are they looking at kind of, how much they're eating? Are they becoming more obsessive about what they're eating and their exercise and things like that? So basically the question is, I guess, who notices it? Are people seeing it? Are people around young people seeing it? Sorry if I'm going too quick. Extended and significant use of social media. So I've said that. Again, that won't surprise any of you. I don't think that, young people are obviously spending more time on social media, and there's more awful, unhelpful things out there. I think a couple of the nurses in our teams are brilliant, experienced people. So they're very skilled at what they do. Joe Wicks, I think, has been about a lot, hasn't he, as a really positive thing. And, I'm sure on the whole, Joe Wicks is a positive thing, but it brings with it problems, and it brings with it this obsession with looking okay and exercise, and some of the messages that are put out there to young people are not helpful, and kind of, thoughts around how people might attach to their identity and how they look and become obsessed by it. People don't always think about that when they're delivering healthy exercise and keeping fit and eating healthily. Are they thinking about people who might have some thoughts of, being not looking okay, or being overweight, or being having an extended stomach or something like that? So all of those things. The impact of lockdown on general mood, anxiety, self-esteem, isolation. I mean, again, I don't think I need to say much more about that. I mean, I guess as a group of people, you will have seen that when you have seen children at school. You probably will have seen some of that. Maybe when I finish this slide, you can tell me. And dieting behaviours. So yeah, again, more rigidity around what young people will kind of eat and what they're doing and stuff like that. So sorry, let me get rid of that. So yeah, more rigidity, kind of more focus on diets, reading more about diets, and yeah, more social media, more comparison with each other, more time to think about it, less distraction, less going on in their lives. And changes in exercise. How do we keep fit? How do we look after our mental health? I need to run more. I need to exercise more. I'm going to go up to my room and do some HIIT exercises, those sorts of things. So could anyone have any thoughts on any of that? Is that a no?
I think that's a no.
Okay. How do I move to the next slide?
If you just hit the right arrow key, it should go over.
Let me just go back.
There we go.
Ooh. I'm just going to go back and just check that where I was. Yeah. Okay. Behavioural indicators. So we think when we're thinking about how we support people who we have some concerns around their eating, so disordered eating. So I guess the first thing to say, which again, hopefully you will all kind of understand, is that changes in patterns of eating don't always relate to an eating disorder. So there's many other things that might indicate, that might cause problems with eating. In terms of someone's mental health, so depression, low mood, not having access to food, anxiety, fear of being sick after eating. So there's many other things that can cause changes in eating patterns. And the earlier we can intervene and help young people understand and make sense of what's going on for them and come to some understanding of what's causing this change in eating or increase in exercise or unhappiness with kind of how a young person looks, the better the outcome. So some of the behavioural indicators of an eating disorder include reluctance to discuss concerns. So when concern is raised by a parent or school, there'll be a reluctance for the young person to kind of talk about that, to want to engage about it, to kind of push it away, to kind of, play it down, I guess. There may be a resistance to being weighed. So again, young person will kind of is not readily going to want to step on the scales and talk about how much they weigh and kind of think a bit more about what a healthy weight is and whether they're at a healthy weight and how they could be at a healthy weight. So there's going to be that pushback from a young person. So as Sarah's put here, evasiveness, kind of avoiding conversations, not wanting to talk about it, getting angry or distressed when being asked about eating problems. So again, stopping conversations, I guess. Increased isolation, kind of, keeping themselves away from other people, not necessarily wanting to be seen, to be recognised, to kind of, people approaching them, wondering what's going on, and changes to eating behaviours. So a lot of the young people we see will come into school and they won't eat lunch, for example, and kind of goes unnoticed. It would do, wouldn't it, in a school, I guess, on the whole, depending on the age of the child. It's quite easy not to eat at school and kind of that not to be recognised. So these types of things, I guess, the question for you guys, if I'm understanding your kind of roles and stuff, is thinking about how you have conversations with young people that allow a conversation about, I guess, identity, self-esteem, how people feel about themselves, which might then lead on to other conversations about some of these things where you might start to find out a bit more if you already had a little bit of a concern in the first place. So were there some things that you were noticing that maybe were raising some concern for you around how a young person looks, about kind of, what they're eating, what they're not eating, those sorts of things. Again, I'd ask you if you had any thoughts on that, really, and kind of what you might notice in young people. Have you noticed anything in schools for yourselves over the past 6 months or a year when you've had children in school? Have you noticed any changes in presentations around disordered eating, so changes in eating patterns and stuff? Did anyone say anything about that?
I work at the hospital school, Chris, and I've certainly noticed that we seem to have a little bit of a spike in admissions for eating disorder since the lockdown. Some of the things that I've noticed, the physical attributes on children, are hair loss, actually.
Yes, exactly. Yeah. And how have you kind of entered conversations with young people about that?
Well, fortunately, I'm a trainer for mental health first aid, so we do actually talk about eating disorders, and we found very much the website Beat is very useful.
Yes,
We've used that quite a lot, and we've signposted our families to use that. But just generally, what we don't do is talk about their looks. So that goes right down to, oh, your hair looks nice today, or anything about their looks. And I think that's come through very strongly in the lived experience training that we have with our young people. Is what they say to us when they've recovered. They come back and say, actually, it's really awful when you say, oh, I look well, because looking well to me means that I've put on weight.
Yeah.
So we try not to talk about how they look.
Indeed, no, excellent. And I think again, I went to see a 15-year-old in a rainbow ward at a hospital at West Suffolk yesterday, and who's been refusing to eat. We're getting a bit more of this complete refusal to eat for many weeks, really, and that doesn't for a while generally send you into any kind of major physical concern, but eventually, of course, it will. And we've had a few young people recently end up in hospital, and again, the kind of formulation, we always contact it as an eating disorder team because they're not eating, but there's often, well, always so much more to it. And for her, it was about trauma around her father and mother splitting 10 years ago, some of the trauma she'd experienced at the in her father's house, not directly, but a very angry dad, basically. And it was always also related to her sexuality, and kind of she saw herself as a lesbian. She's 15, saw herself as a lesbian. She's accused someone of sexually assaulting her at school last year, so that was all kind of playing out for her. She was struggling with her new family at home. Mum's remarried, and she'd literally stopped eating. She's lost 10 kilograms in the space of about 2 to 3 months, something like that, which is really concerning and significant. And kind of, you go up there as a professional and sit in front of her, there's no point starting straight away talking about kind of, what are you eating? Could you try eating this? Could you try eating that? You have to get to some of that, but it's about thinking about who the young person is and their identity, and kind of, what makes them tick, kind of what's gone on for them, kind of, trying to hear, let them have a voice, and kind of think a bit more generally with them about how it is to be 14, 15 in the world, how it is to live at home, how it is to be at school and to have experienced some of the things that she's experienced, where she sees herself in the future and stuff like that. So that more general conversation about general mental health and stuff like that is always the better place to go. And a good one is always about kind of identity and who you are and what you want to be, the values you have in life and those sorts of things. So yeah, I mean, I guess they're the sorts of things that you need time to have, aren't they? You need time to have those sorts of conversations. Is there any other comments on any of that? What else have we got here? So we've got some diagnostic features of an eating disorder, thinking more about anorexia and bulimia. So restriction of energy intake. So again, we're thinking about, again, many of the young people, the girl I saw yesterday has been taking about 600 calories as a maximum really for the last kind of couple of months, hence the significant weight loss. So counting calories, getting obsessed with calories, checking packets, looking at what they eat, eating more salad, eating more fruit, reducing carbs, all of those sorts of things, as you all probably already know, they're all indicators where we should be concerned, might indicate an eating disorder, but certainly are a concern anyway related to physical health. Severe weight loss or significantly low weight for age. So again, under 18s, we look more at what we call weight for height. So we get a weight for height measurement. A healthy weight for height generally is 95 to 105%. And if someone's under 95 and that goes below kind of 90, we start to get a little bit more concerned. And we have something called a Marzipan Scale, which is a scale we look at weight loss and where someone's weight's sitting. So it stands for, it's an odd thing, isn't it, Marzipan? Some of you might be smiling at that, but it's about managing people with anorexia. So if you were to Google Marzipan Scale, you'll learn a bit more about that. But it means we're checking out someone's physical observations, their weight loss, what weight they're at, and all of those things. It's a risk management system. So we use that in our service to kind of think about where risk sits mostly. So it's either green, amber, or red. Sounds simple, much more complex when you read about it. So yeah. Intense fear of weight gain. So obviously, again, I'm sure you've all heard and read about some of these things in terms of, so again, the young people I've seen recently have talked about specific parts of their body. I've got too large thighs, my stomach's too big at the bottom. Those sorts of things kind of, young people, mostly girls tend to say to us. So distorted body image or lack of recognition of seriousness of weight loss. So the young person, again, obviously won't really recognise some of these concerns. When you're saying to them, but your weight for height is is quite low. You're at 81%. You know, that means that may explain why your periods have stopped, which would be one of the signs of weight loss. It might explain why your hair is thinning. It might explain why you're getting some chest pain. You know, the young person, in the very nature, if it is anorexia, will not get that. They'll not see that. They'll have the anorexic voice in their head saying, you're too fat, your stomach's too large, your thighs are too big. So, you know, you've got this real battle. You try and talk to the young person about that voice in their head, really, the anorexic voice, and kind of help them understand it as an illness, which of course is what it is. So a complex thing, really. So compensatory behaviors. So you may get purging, which is basically self-induced vomiting, so that in bulimia, excessive exercise and laxative use. So there's some of the things that young people may do to try and compensate for when they feel they're too fat. So as I say, even at kind of 81%, 80 to 85% weight for height, some young people may still, most young people who have anorexia or bulimia will feel that they're too fat, and they'll want to change that. If someone's weight for height reduces to below 80%, we become more concerned and they become amber on marzipan, and we kind of have to monitor them, kind of observe them more regularly, so on a kind of weekly to fortnightly basis. And if they lose more weight, then they move to red on marzipan, and we'd then be looking at a kind of hospital admission to think about you know, risks around their blood pressure, pulse, heart, all of those sorts of things. Symptoms of low weight that you might notice in someone, I guess, if you noticed they were pale and they were kind of very thin, so loss of periods, feeling cold, dizziness, would be other things that you may recognise, chest pain, fainting, those sorts of things would be things that, you know, kind of might come up. I'm going to get rid of that. In some patients, recurrent binging, so lack of control over eating. So we meet some young people who may also binge and purge. So they may eat large amounts of food for periods of time, phases of time, or maybe just in the evening. And they will control that intake by purging, by making themselves sick. One of the risks with young people that purge is their blood results, so potassium and sodium. Again, that can cause significant problems, so we have to monitor their bloods, and again, they may need a hospital admission if there's problems with potassium and sodium in particular. So that all probably explains some of the, I don't quite know what I'm pitching here, so I don't know how complex you want me to go, but the seriousness of kind of weight loss and some of the symptoms that you may see, and some of the concerns that, you know, the hidden side of eating disorders, I guess, really, you know, you won't see it very obviously sometimes, and it's hidden. And how do you ask the right questions in your roles to think about what may be going on? And as the lady who spoke earlier said, I think the skill and the art, if you have the time, which is another matter, is to try and think a bit more generally about, you know, identity, general mental health, kind of, you know, how things are for someone, kind of what's going on in their world. Those more general questions might lead then to more specific questions about identity and how someone feels about themselves. They're the questions you need to start to get to try and make some sense of what's going on for someone. Does any of that make sense? Any questions? Okay. So again, as an eating disorder service in Suffolk at the moment, because we've been under-resourced for the last 4 or 5 years, and we've had an increase in referrals this past year because of COVID, we don't actually at the moment accept many. We happen to have been caught with a few, but we don't take on ARFID, avoidant restrictive food intake disorder. So you'll see this in a lot of young people with autism or ADHD. So often hypersensitive to certain types of food, have fear of certain types of foods, the smell, the taste, the texture, all of those sorts of things. So we have a few ARFID cases that have snuck through, really, but most ARFID cases sit up in, need to come off that, most ARFID cases sit with our community dietetics at the moment and community paediatricians. They're not very happy about that. They think that we should be doing that as an eating disorder service, and most research and evidence shows we probably should. So we're looking for more funding from our commissioners at the moment as part of our business case to get more monies for our service to deliver what is a very complicated service, really, because if you can imagine someone with autism, I'm sure you've all met them in some guises, who's not eating because they have all the things I've mentioned. They need quite intense home support. They need people to be going to see them at home, trying to get into their world, to see things from a kind of autistic perspective, to understand where they're coming from. It's not a typical eating disorder, so it's very different. These young people aren't usually trying to lose weight because of how they look. It's to do with lack of appetite, sensory sensitivity, or anxiety. Anxiety being a key one again, really. So they don't have a fear of weight gain or disturbed body image or weight loss. So this is about sensitivities to food, and it's a very different kettle of fish, really. And Sarah's put something in there about the Suffolk service. Again, I don't know if any of you come across this much. I'd open that up if anyone's come across it, maybe they could say. Interesting. So again, I guess...
Sorry, Chris, I have come across it in the hospital school. I just don't want to keep being the one to...
No, you're fine.
Yes, we have come across it. And how do you treat a child with autism and sensitivity with their food?
Over a long period of time. I would say this is the problem. This is why services like ours can't commit to it with the resources we have, because I'm thinking of a one ARFID case, and they often end up really seriously at risk, because they often end up with a weight for height in the 60s or 70s, and that's really serious and really concerning. And you have to, they're often known to paediatric services as well. You have to check their bloods really carefully. They sometimes end up in and out of hospital. What they need, and the case I can think of that I know quite well, what I needed to do over a period of time was do lots of home visits, which is not what we normally do in our service. We do a bit of that, but we expect people to come to us on the whole. Lots of home visits and working with parents and families to try and work on the sensory issues, really, and kind of psychoeducation about risk, because the young person with autism obviously doesn't understand usually. So psychoeducation and building up slowly, bit by bit, different foods into their diet, whilst monitoring all of these physical health risks. And it takes months and months and months often to make any change, with fairly significant risks playing out. So I was talking to dietetics at West Suffolk Hospital recently, and they reckon they've got about 86 people on their caseload at the moment, and they're very frustrated because they think they need more, and they do need more than they can give. There's a lot of people in kind of West Suffolk. They don't all have autism and ADHD, but a large part of them do. So yeah, very complex, and it needs to be a specialist service with time to be able to commit to this group of people. So if you look across the region and the country, you'll see more and more eating disorder services being commissioned to pick up these increasing numbers of cases whereby people are not eating for these reasons.
Thank you, Chris. We have got a hand up.
Yes, got a hand up.
Hi there. I was sorry if you said this already. I'm at home sorting out children as well as trying to listen to this. Can the avoidant restrictive people, can there be a crossover with someone who is like that, but then can also
yes, good question.
Eating disorder?
Yeah, no, that's a really good question. And how do you diagnose clearly? And it's a real, again, a specialist thing, diagnosis. So there can be a crossover, but I'd say generally not. I'd say in my experience and the teams, that it's usually fairly clear cut. So there's different diagnoses in kind of eating disorder. So there's atypical anorexia and as well, and also other eating disorder problems that aren't related to specific desire to lose weight because of body image. So like I said before, anxiety, depression, all of those things. I'd say with a good formulation and making sense, this group of people kind of pretty much does stand out to the kind of trained eye. They do stand out. So the overlap is not all that significant. But yes, sometimes it's hard to get to a formulation and and a summary and a diagnosis. It's not easy, and we have to be curious with people for a period of time unless it's obvious, because like this girl up in the hospital, you know, do I think it's an eating disorder when she's talking about all of these things? I think it's much more than that. So she may get diagnosed with anorexia. She'll probably go into hospital, but all the comorbidities, the trauma, the stress, the family dynamic, they need family therapy for sure. You know, there's so many things driving and holding the eating disorder there. So it's not just an eating disorder in its own sense. It's a wider group of things that hold things for people. You know, where does it stem from? It's not just the genetic factors, it's also the causal factors, what's gone on in the person's life, what's happening in their life, where do they, you know, what goes on in all of the different environments they're in. Does that make sense?
Yeah. I mean, because when you were talking about the restrictive food intake disorder, I was thinking of someone that I know who definitely seemed much more like that. However, as time went on and she reached puberty, then also became very conscious and was bullied, I think, as well, because of her looks. And then it started to be like, oh, is it just the fear of the textures and all those kind of things, or is there now something else coming into play? And I was just wondering.
And I think that overlap is really important to note, because it's not, I mean, diagnosis is one thing, but you know, we always need to be thinking about what's the treatment and what services need to be involved. And this is the problem if we get caught into separate, we do this and you do that, and you know, the whole drive at the moment in young people's services is to try, you will have all experienced that, I'm sure, and been frustrated by it, but is to try and bring services together to have a whole systems approach and to respond in a way that allows people to consult with each other and not say, well, they're yours and they're mine and they're a young person with different kind of needs and with other general mental health problems. I think we're doing that better now. Now we're in a new care group the last year within NSFT, which I'm sure you all know about, but we're under a new care group now, all 0 to 25 services, and I think we're doing much better at that. We're seeing things in a different way. We're aligning with kind of well-being, secondary care, eating disorders. We're aligning much better. The issue we have at the moment still is resources in all those services and increasing referrals. That's our issue, and fighting for money, I mean, I guess. But...
Thank you.
Okay. Oh, I keep losing my arrow. It's up there. I'm sorry, you can see I haven't done this very much, can't you? Right. So again, referral to an ED team for someone under 19 with probable eating disorders. Members of school community can refer by, so you all know about the Emotional Wellbeing Hub, I expect. But again, more urgently, you'd be looking for medical attention, and that would be a GP, not necessarily us, or a hospital, A&E, somewhere like that, for rapid weight loss. So we're thinking there more. That won't mean much to you, I don't think, necessarily, but when someone is losing weight rapidly, that's our concern. So over half a kilogram a week, over consecutive weeks would be the most significant concern. And then, of course, their current BMI. So we all know about BMI. Like I say, weight for height is the same sort of thing. We just use a different measurement for under 18s. So, you know, anyone with a BMI in the adult population of below sort of 15, you'd be starting to get really concerned about. Anyone with a weight for height or BMI under 18 of kind of 80%, 85% or below, you'd be concerned about. But with children, you'd be thinking of noticing all the things we discussed earlier. So changes in their physical presentation, that's what you'd be looking at. So I've said about the loss in weight. So again, the other things we check, so when we bring young people into clinic and do an assessment, and we also have a physical health clinic that runs weekly. Something called Brachycardia, which is a kind of low pulse. So a heart rate of, I'd say, under 45, really, under 40, 45. And we'd be concerned about that. So a low blood pressure. We'd be concerned about, we always ask for bloods and ECG because they can show abnormalities in many different things, as you would know, but potassium, sodium in particular. They would also, urea would be related to severe dehydration and a significantly low temperature. So again, I'm not sure how that slides all that where it's relevant for you necessarily, but for helping you if you wanted to know what we would consider urgent. They're the sorts of things that we would be looking at in terms of something being more urgent. And these kids are coming to our service plus at the moment. You know, every week sitting in the West and East meetings, we're getting referrals where the weight for height is below 80 before they get to us. Where we're thinking about early intervention and stuff like that. It's kind of almost a bit too late, really. I guess that's where you guys come in, and when we think a bit more with you all about kind of, you know, how you recognise the need to have conversations with young people about kind of, you know, their weight, their height, all of that, and how you would go about that. Quite a complex thing, I would say. Any thoughts on any of that?
Chris, I've heard it said that it takes just 2 weeks for an eating disorder to take hold. Do you agree with that?
Where have you heard that said? Out of interest.
I think it's just
generally,
something that I've been told generally.
So say it again. Sorry, say it again.
It takes almost less than 2 weeks for an eating disorder to take hold. So that's why early intervention is so key, and that's what you've been referring to. Would you agree that that's a fact?
No, not really. No, I think it's more subtle. I think it kind of, you know, what we may be presented with in the end may well be someone that's more serious, and you might think, wow, where's that come from? But it's more subtle. Pretty much all the young people I've met along the way, you know, if you get in there early, what I mean by that is someone's noticed it earlier, or a parent self-referred, and by early I mean I guess someone's not right down kind of below 80% weight for height. They haven't had significant weight loss, but they've started, the parent family school has started noticing some changes in their general mental health and in what they're eating and how they're viewing themselves, maybe some increased self-harm, stuff like that. I think it's subtle. I think everything I've seen is about people presenting, you know, bit by bit, noticing changes, things like that. It's just when we see it, it's kind of there in our faces. I think that's always a better way to look at it, if that makes any sense. Does that make any sense?
Yes, it does. Thank you.
Okay. Where am I? How many more slides? Am I doing all right for time?
Yes, you're absolutely fine for time. We've still got about 20 minutes.
Okay. So I get rid of that. I've got a bit over the top of the top bit. How do I get rid of that? Oh, I don't know. What
are you referring to? We can just see the slide.
Can you see the slide? I've got something in the way there.
Oh, no, we can see that. We can just see the first bullet point, include weight, height, pulse.
Okay, sorry, thank you. You've helped me there. So include weight, height, pulse, blood pressure and temperature. So when we're thinking about a physical kind of health clinic and what we're looking at, again, as I've said before, it covers all of those things, because that's what we'd be doing as nurses. We'd be checking all of those things for obvious reasons, as I've described. Any previous records of weight or height, even if years previously. So what's the kind of history in terms of a young person? So you get many young people that have always been thin. They'll be the words that you hear from parents and stuff, and that's true. So kind of, you know, as they've developed, their weight centile has kind of always been a bit under what you would consider normal. That's okay. That's fine. If that's always been the case and that's where they're sitting and there's no physical symptoms and they haven't got an issue with their body image and they haven't got a desire to lose weight, that's okay. But they may present to us because someone will say they're very thin. They're very thin. There has to be other reasons, and you have to look at other organic causes. So, you know, we need to check out many other things that might be causing someone to be at a low weight. So behavioural concerns and changes. Concerns about overall mental well-being, safeguarding concerns. So I guess, again, you know, thinking generally about mental health. So as you would all do in your roles, and any safeguarding concerns. So kind of, the conversations you have with families, the conversations that need to be had with families, when a safeguarding referrals needed to be made. So Sarah's put on here ways you can make a referral to the hub through referral form to the emotional wellbeing hub, and the phone number there for contacting the hub. So if you just put some details there. What else have we got? So school support, this is probably a bit more relevant. Vast majority of young people with an eating disorder will maintain full school attendance throughout the course of their treatment and illness. So again, that might raise some thoughts for many of you. I guess, what do we mean by that? So like with any mental health problem, really, so if a young people presents with emotional distress or problems with low mood, some self-harm, stuff like that, whenever possible, we want them to continue to function in life. We want them to continue to move forward. So we will be helping them learn about how to manage their emotions, how to manage what's going on for them whilst living their life. Again, it goes without saying, really, when people step back from life and step back from doing the normal things that bring good mental health generally, they're going to become more isolated. They're going to become, so it might feel a safer place to be, but they're going to become more isolated. They're going to become more stuck. They're going to find it harder to get back to school. So generally, people, despite how they feel and how they are, unless it's really serious, obviously, should be continuing to access school and do the normal things in life that anyone else would be doing. But that might be slightly controversial for you guys. I don't know. You're welcome to challenge me and talk about that if you want. They may require modifications to the timetable, such as changes to PE. So we would be liaising with schools and thinking a bit more about the young person, what they should and shouldn't be doing, much to their dislike, obviously, because they don't see their eating disorder as a problem and they don't think they're low weight. So they will not like that at all. But we'll be liaising with you, and I'm sure you've come across that. Will require time to attend treatment appointments. So again, goes without saying. May require modifications to exam programming. May require support around meal times, environment, other immediate support. I would imagine that's a really difficult thing to do in school, especially for kind of secondary school pupils. And again, all of our conversations with families and young people are about they don't eat at school, they don't eat at school, and you're kind of like, how are we supposed to impact on that? It's a really difficult thing, isn't it? So it doesn't have to be the key thing, really. I mean, it's obviously going to help their learning if they're having something to eat in the middle of the day in terms of concentration and focus, but it's a really, really hard thing to monitor and to kind of be sure that people are eating, and it can cause angst and agitation and all of those things. And you've got obviously people on this call are in a school doing a job with 101 other things to focus on, whether a young person is eating or not. So it's a very tricky thing. So we'll try and talk and engage with people in schools around those sorts of things, and in a very, hope you feel in a realistic way, really. How do you maintain friendships? How do you maintain kind of, the people around you that matter to you? How do young people speak to other people about their eating disorder or the problems that they have? How do they get the support they need in schools? Obviously, you've got the mental health in schools now, kind of, well, certainly in West Suffolk, that's kind of rolled out pretty extensively. I obviously don't know what schools you're all working in, and I presume they're more East Suffolk, but certainly in West Suffolk, the mental health in schools thing has been quite a useful thing in terms of us liaising with those people and kind of linking up with treatment and thinking about what support young people can have in school regarding their mental health and or eating disorder. Young people may be worried about how they keep up, how they keep going, how they keep their focus, because if they're losing weight and their weight for height is reducing, then they're going to struggle to kind of maintain their mental ability, basically. And the impact of physical and psychological state on ability to study. As I've just said, really, energy is required to compensate for this. So again, I'd welcome if someone would be able to just say something. I mean, has anyone got any experience of working with someone with an eating disorder in their school? I'd be surprised if they didn't. No.
Yes, I have.
Okay, and are you hearing all of this and thinking about that young person? Is it what's it been like? And what's your name? Sorry.
So my name's Jo, and I work for a local college. I've been working with a student for some time, and initially we didn't realise it was an eating disorder. She actually came for support with bereavement, amongst other things, and the eating disorder was very difficult for her to talk about. So it took a long time to build up that level of trust with her, first of all, and it's been increasingly difficult to signpost her, to be honest, because she hasn't had a very good previous experience before coming to the college, and trying to then signpost her on for more specialist support has been quite difficult. So this has been really useful, actually, because I'm trying to kind of support her within the realms of building this level of trust, with the view to then signposting her on again once she's a little bit more comfortable about talking about it.
Yeah, and it's that early stages, isn't it? It's that sense of trying to get there before anyone is even thought about a referral to an eating disorder service. Where do you notice these things? How can you kind of find time to have conversations with people? That's the tricky thing, isn't it? Because it's so hard to see what's going on for young people at the best of times, never mind what they're eating and drinking, and kind of how they're feeling about the way they look. It's a really tricky thing, isn't it? Yeah, complicated stuff. And I think one of the things we haven't been able to do as a service over the last kind of few years I've been in post, because of the resource issues we've had, we should be more visible in schools. Occasionally we should be kind of giving you some resources to put in your schools, and a leaflet that says something that may attract a young person to it, to kind of think, is this a problem? Have I got this problem? Is there someone I can talk to who's got a similar problem, even if it's not a professional, someone else who's been through something similar to what I might be going through? I know we haven't been able to do that enough. I know Sarah, who's my manager, has been tries her best to get out there and do things like this, but it's a resource issue again for us in terms of kind of having the time to do these sorts of things. It's a kind of tricky one. Okay, I'm probably near the end, aren't I? I think. Not quite. What information to give to young person and parent? So the parent or young person will be contacted by ED team by telephone. Assessment will be carried out within 7 days if urgent, or 28 days if routine. So that's something called the access and waiting time standard. So nationally for eating disorders, if someone is referred to our service nationally, we're monitored really closely on this, and our commissioning depends on this to a degree. So we have to see someone within 7 days if urgent referral, and 28 days if routine. In the last year since COVID, that has been completely scuppered, really, I would say. It's been a nightmare. So it's much longer a wait now. That has come to the attention of our commissioners and stuff. We've got a business case that's been in a while now. But the impact of COVID is no one's fault, is it? It is what it is, and we can't take that away. And the increase in referrals has knocked us, as has staff sickness and related to COVID as well, to a degree, in our eating disorder services. So that's our standard. We're struggling with it at the moment. The young person will always be seen on their own as well as with the family. So the main intervention in an eating disorder service for young people is called family-based treatment. So I guess you kind of think of family therapy with an ED kind of theme to it. If you looked at the Maudsley model, so that's the Maudsley Hospital in London, they kind of developed the family-based treatment approach for anorexia. There's also an approach for bulimia. In a nutshell, it's kind of anywhere between 20 and 40 sessions. At the beginning, more intensive, at least weekly, sometimes twice weekly, family-based sessions. You might split the family a bit, you might split the young person away a bit, but it's a family-based treatment, and it follows a specific model of intervention. So if you wanted to learn more about that, you'd look at family-based treatments and the Maudsley model if you're interested. That's the main intervention with someone under 18. So it's all systemic family work. And there's also some individual psychological work with comorbidity, so additional problems a young person may have, for example, anxiety, depression. So treatments early, I've said all of that, involving parents in early stages, all the physical health monitoring. Generally, we don't use medication in any young person under 18 unless it's absolutely necessary. Kind of the idea is that psychological interventions are key, so that would be the NICE guidance. It's the National Institute of Clinical Excellence would be indicating for any young person with depression or anxiety that they should have a psychological intervention first. That's why you don't really see many people under 18 on an antidepressant or such like. But there's a few, which is why we have a kind of CAMHS consultant. So when it's really needed, I'm sure you've all come across one or two people on fluoxetine, an antidepressant. Has to be monitored really carefully in young people because it can cause an increase very rarely in suicidal ideation. So it can't be, antidepressants under 18 can't be prescribed by a GP. Sometimes they are, very naughtily, but they should be prescribed by a CAMHS consultant after a proper assessment and ongoing monitoring until they're 18 because of the increased risks of suicidality. So generally you won't come across too many young people who are on a proper antidepressant like fluoxetine, which would be the first use of first medication we would go to if we were treating depression or anxiety after psychological intervention. So there's a group of people we see with our CAMHS consultant that are on medication, but not many. Any questions on any of that really in terms of how our service works and medication and mental health, anything generally really, because I'm happy to answer any questions around young people generally.
Thank you, Chris. There's not a question, but in the chat bar, Lynette Torbett has put that she's a teacher working with small nurture groups. She's very frustrated because she hasn't got any audio and can't say this out loud, but she's written it. She would like to recommend, she's done some training with Taste Life, an accredited charity, and she said there's some amazing resources there. They've recently made resources for teachers in schools for ages 11 and above, and she really recommends it. I don't know if that's something that you've heard of, Taste Life.
I haven't, no, interesting.
But thank you, Lynette, for putting that up there.
Thank you, Lynette. Yeah, I'll have a look at that. Thank you. The services we use, again, Sarah's put at the bottom there. So Young Minds, Beat, Kooth is quite popular at the moment. I'm sure you've all heard of Kooth, K-O-O-T-H. That's there. Young people are finding that quite useful regarding their mental health and contact with people. There's an organisation called Wednesday's Child. I don't know if anyone of you have come across that. So Wednesday's Child and Beat are the two ED places that you could kind of, be having a look at yourselves, maybe arming yourselves with a bit more information, thinking about when you might mention those two organisations to a young people. They're very open to kind of more general acceptance that an eating disorder is not a sort of set specific thing necessarily. It's about thinking about what's going on for the young person. They're not scary places to go to for young people. They're supportive, open, kind of want to engage and think a bit more about what's going on for the young person. They're not straight to looking at diagnosis and classing someone as having anorexia or bulimia. Which is quite right. We need to always be curious and thinking about why someone's presenting with restricted eating or purging or any one of the other things that I've said earlier. So yeah, there's some websites there for you to look at. Is that my last slide, do you think? Ooh. Now, I've obviously just wanted to say I've come into this today having literally glanced over these, and I didn't quite know exactly what you wanted from this and the kind of the agenda. What would be useful to you? Now, Sarah's obviously had a good go at putting this together and thinking, I think this will be most useful to people. I guess I can only really be of help to you if I can be of more help to you if you want to ask anything else, or if you want to kind of send anything to me via email by the person organising this meeting. I'm more than happy to come back to you via email. You can have my email address if you want it, and I can talk to you more about certain things if you want to. But I'm more than happy to answer any questions about young people, general mental health, eating disorders, anything there that's not clear, or if you had expectations that today would be different and you needed answers to different questions, or how is it for you as a teacher or an assistant, or whatever your roles are, how are we supposed to do this, how are we supposed to help, if you've got any of those sorts of questions that I haven't covered in whatever time we've got left. It's, you know, whatever. Yeah, does anyone want to ask anything?
Just while you've got this last slide up, Chris, I was just really putting a plug out there for the Beat website, and to explain as a teacher why I found that particularly useful in my practice. And we haven't touched on it really today, but it's the effect on the siblings that is also quite important for us to look at. If we've got younger brothers and sisters, or indeed older ones in the school, or if we know of them. And I think it's good to signpost parents to this particular website, because they do support the siblings as well. So, you know, what's going on? Why are meal times at home so stressful? And I think that the effect on the sibling is important for us in schools to recognise.
I think that's a really good point, and some of the work we do, we'll support siblings as part of the family-based treatment. So all of those sessions will involve siblings coming along to some of those sessions. We might offer a separate session to a sibling if they're asking questions, if they're confused, if they want to know more, if they're anxious and worried about stuff. So all of the family-based treatment involves a flexible approach to thinking about families. So for example, this girl I was speaking about in hospital, really interestingly, her mum and her dad split up, I think I said 10 or 11 years ago, and she hasn't seen her dad for a year. And there's this kind of background to him being angry and cross, but her sister, who's 2 years younger, sees him every other weekend and goes there and comes back and has a lovely time. And when I went to see her yesterday, she said her mum was sitting next to her, and she said in an excited voice, "My dad's coming to see me tomorrow. He's going to stand here and talk to me. I'm seeing my dad for the first time in a year." I thought to myself, my word, it's taken this to kind of end up with you having a face-to-face with your dad. Now, you know, what needed to happen some time ago, we didn't know her, is that there needed to be some therapeutic input from someone like our service or a youth service to kind of try and work with getting the daughter and dad reconnected. The trouble is, the mum's narrative in it all is in front of daughter, who's 15, is dad is angry, dad threw something at a wall when you were younger, dad's not very good for you, dad doesn't understand, all of those sorts of things. So, you know, that illness, whatever she has, the trauma, maybe an eating disorder, she's not eating for 3 months on and off for the last 2 or 3 weeks completely, about to go onto an NG tube, nasal gastric tube, and yet the next day, for the first time in a year, her dad is coming. That, to me, as a professional, speaks huge amounts of things. There's so much work needed there to think about what that's all about. Family therapy would be needed going forward. That would be the key intervention for her going forward, whether she's in an inpatient unit, which she probably will be, or back at home, will be family therapy to kind of pull all of that apart, get the right people in the room and think a bit more about the dynamics, what's being said in front of the young person, what's being understood by the young person, and kind of, you know, where we move forward. Does that make sense?
Yes, thanks, Chris. That's really good. Thank you.
Just an example. It's better sometimes to use real examples, isn't it?
We see a lot of those children in the hospital. So yeah, you're right, you've hit the nail on the head there, and it's good that you spend time obviously looking at the siblings as well. I wasn't aware that that was part of your service.
Yes, no, absolutely, a really, really important part. And like I say, different family members and repairing relationships, and not letting the kind of the narrative stay as, you know, I hate my dad because everyone tells me I should, or I hate my mum, or, you know, there's reasons sometimes where young people shouldn't see their split parent because of abuse and stuff like that, obviously. But, you know, other than that, we should be looking at how we help the adult repair the relationship for the sake of the child, and that's a lot of the kind of work that we do.
Chris, I'm conscious of time, and I was wondering if there was a way that perhaps you could put are you able to share your contact details, or can we email that out to you if any of our members here today have got any questions for you? Yes.
Do you want my email address?
That would be lovely. There is a recording of this presentation. So I hope that's okay to go onto our website. It's been really useful. Thank you.
I think I say to you, Sarah, I think I don't know it's being recorded, and I probably shouldn't say this out loud, but Sarah would have done I've done my best, but I think Sarah would have obviously been prepared and has done a better job than I have, but I've done my best, and I'm sorry if it's probably maybe not quite what you would have had from Sarah, but yeah, I've done my best. That's all I can do, isn't it?
Absolutely not. You've been absolutely brilliant. So thank you very much, and for stepping in at the last minute. So I think if there are any further questions, we'll just open the floor for a couple of minutes now if you want to ask them. If not, if you can type them in the chat bar, and we'll ask Chris to provide us his email address, and we'll email it out to you. Is that okay?
That's fine by me. Yeah. Yeah.
Okay, well, thank you, Chris, very much.
That's a pleasure. That's a pleasure. Nice to meet you all.
It was really informative. Thanks, everyone, for joining.
Thank you very much.
Okay, thank you. No worries, no worries.
Thank you.
You all take care.
Thank you very much.
Bye. Bye.